Okay, so I'm in the Department of General Practice and Primary Healthcare. I work as a GP in Manurewa in South Auckland. My PhD was on hypertension, looking at exercise and sodium restriction, which I can talk to you about a little if you want to know. But I was going to talk more about how to assess and how to treat with medication rather than lifestyle. But lifestyle is important for all the other reasons for the total cardiovascular health. So I always like to show this picture. This is a Yanomamo Indian. And this is an indigenous tribe that lives in the back blocks of Brazil and Venezuela. And the average blood pressure in that community is 95/60. And it doesn't go up with age. Like in our community, as you get older, your blood pressure goes up. Whole lot of reasons for that. They're quite small. He's about the size of sort of a typical teenager in New Zealand. Their alcohol content is low. They get tons of exercise. They do lead a violent life because the men fight with each other because they like having multiple wives. The original anthropologists thought they fought over food, but they missed the point. They were fighting over women, basically. But the key thing about these guys is their sodium intake is 1 millimole a day. Now, everybody in this room, unless you make your own bread and cook everything from scratch, will be eating probably 150 millimoles a day. If you eat a typical Asian diet, it'll be more like 300. So it'll be somewhere between 150 and 300. It hasn't been measured very recently, but that was about what I found in my study. But I wouldn't recommend sodium restriction. Most people don't like doing it. When I did my study, the people in the exercise group used to bake me cakes, and the people in the sodium group just complained for 6 months. So you know, people like being told to exercise. It's a great thing to do. So I've been a GP in the Department of General Practice since then. I've been head of department again now, just recently. I did have a picture of rural Canada, but I did take it out. I did my family medicine training at McMaster. Just at the time, evidence-based practice was starting, which was quite interesting. Been involved in Cochrane reviews. My research interest is sort of stuff you can use tomorrow. So it's a bit like the Goodfellow unit. Our motto is skills for next Monday. So hypertension, so I just thought I'd just go a little bit through the epidemiology of hypertension and just look at time, place, and person. And we know a lot of this stuff through cohort studies, and we've got more than 50 years now of randomized trials because they knew hypertension was a risk factor, but it really wasn't until the 1960s, I would say, that there were effective treatments for hypertension. First trial was done in 1967, the Veterans Co-op study. That is amazing to look at. These people's CVD risk was probably 50% in the next 5 years. There are a bunch of men, they were in the Veterans Hospital, and they treated their blood pressure. In fact, I think they didn't measure their systolic, they just measured the diastolic, because that's what we were all taught to treat. Those of you who are long in the tooth like me will know that's what we were taught to treat. And they had to stop it after 18 months because the benefits were so dramatic. I mean, these people were going to have an event, 50% CVD risk in the next 5 years is pretty massive. Hi, come on in. That was with triple treatment back then. But this was preventing dissecting. This wasn't just strokes and heart attacks. This was dissecting aneurysms and, you know, aorta ruptures and various things. It's quite dramatic to read. But I thought I'd just like to show you this. So this is data from China, and this is what hypertension is. Now, there's no point in, Rod Jackson is famous for saying there's no such thing as hypertension. It's actually a continuous curve. Okay, so it's more to do with your CVD risk, which is up here, and over here is blood pressure going up. This is CVD risk, and this is a logarithmic scale. So that's 256 times that. And you can't point anywhere there as to where hypertension is. I mean, we have guidelines when you start treating and where you treat too. But in fact, the higher your blood pressure, the higher your risk. But I think the thing that's most interesting here is what happens with age. It's really going up. And you talk to 80-year-olds, and it's no surprise to them because all their friends will be having heart attacks and strokes. when my parents were 80, they used to go to, their social outings were a funeral every month, basically, till their friends all died. And one of the games I like to play, if you only had 5 years of blood, okay, there's been global warming, Brexit's destroyed the world, Trump's caused World War IV, and we've only got 5 years of antihypertensives left. Who do we give them to? Would we give them to the 40-year-olds, the 60-year-olds, or the 80 to 89-year-olds? Now, my answer to that is the 80 to 89-year-olds, because they're the ones who are going to get the bit. Numbers needed to treat up here are about 5. Down here, it's like thousands. You have to treat a lot of people down here to prevent an event. Up here, you don't have to do too much. You see, like you drop a few millimeters there, and you're dropping like a risk of about. Now, I'm not suggesting. You've got to be careful, of course, because little old ladies and little old men, you don't want them falling over and breaking their hips. But if they're reasonably robust, my view, I don't know what your view, Jerry, is, because the American guidelines actually said you're allowed a higher blood pressure up here. That was the previous ones. Couldn't believe it. High-risk people, and you're allowed to have a higher blood pressure? Well, doesn't make any sense, and this is like 1 million people in here. But it's a great, and actually as Rod says, hypertension's probably a line coming across over here. You're like, where is hypertension there? It's all about risk. And as you know, with blood pressure, someone comes in and their blood pressure is 160, they sit in front of you, it's in 140, and then it's 130. Well, what the hell is their blood pressure? It really is hard. Paul Glasgow from Australia says you have to measure blood pressure 22 times to get an accurate estimate of it, to truly know what it is, because it's jumping around all the time. It's like when I say to my page, it's like when you drove to the office today, you were standstill at one point, then you're at 60k, then you're at 30k. Well, blood pressure is a little bit the same. They sometimes get a bit confused about blood pressure and speed, so you've got to be careful with your analogies. So that's the line where we absolutely do treat, and then that's the target we treat to under the Heart Foundation guidelines. There are additional benefits in going down to 120, but it requires more medication. And sometimes I'm going to show some cases later this morning where you're piling on the medication and the pill load's becoming a bit of an issue for people, and they're getting a bit twitchy, But the blood pressure drugs aren't fantastic, 5 to 10 millimeters on average for most of them. So you got somebody up at 180, 190. That takes quite a bit of medication to get them down to 130. So this is the Heart Foundation guidelines. So these are Jerry's original slides. So that's when we do the risk assessment now. So you'll all be familiar with that. And this is the tricky one. And it'd be interesting. I remember asking this question a couple of years ago, Jerry. The issue is what to do with these people, because if you do their CVD risk, it's going to be low because of their age. So I think you have to look at what does the lipid pattern look like. If it's starting to look a bit dicey, or the HbA1c's cruising up to 40, or if they were pre-diabetic at that age, of course, you'd be quite concerned. But, the problem is if you do a formal risk assessment on people, it's going to be low because they're 25. The average 25 has got, virtually, 1 or 2%. At the moment, do you know about the therapeutics collaboration? It was one of my gems, the cardiac risk. So if you go to the Canadian website and click on, I'll show you how to get to it. You can get, and the risk is interesting. My risk used to be 12% on the old one, on the Framium. It's 6% now. So it roughly halves the new equation, which is what Rod Jackson has got from primary care data, which every time you do a risk assessment, it goes through to his, anonymously, it's all encrypted, and then they look at what happens to people in hospital. So he's got 500,000 people, got a massive bit of information. Yeah, so with this you have to think, you have to keep your thinking hat on. The other thing is with pre-diabetes, there's some work from counties. Once people get over 45, they tend to race away. So they're the ones below that. If they're old, if they're 70 or 80, it's probably not going to go anywhere. But it's your 35-year-old who's got HbA1c of 45 is the one you're going to have to watch, because I've had a few of those get away on me, and suddenly they're up at 60, and you think, hell's teeth, how did that happen? I was asleep at the wheel. So this is treating lipids, so recommended to all patients with CVD. Now, of course, that's a negotiation. or anyone with a 5-year risk greater than 15%, regardless of LDL level. So although we assess risk on HDL, total HDL ratio, we do tend to treat to LDL as the target. I think the issue is the total to HDL is the better predictor of disease, isn't it? You and Fraser used to have that.
Yeah, it's the better predictor of risk at a population-based level. You know, whereas this is a better target for management goals, isn't it? You know, and we know any data that we have around LDL reduction, there is no lower limit where the risk of bringing LDL further is negated against something bad happening by doing that. I mean, many years ago we thought that there was an increased risk of suicide, for example, with some of the early trials.
That's right, Jim Fibrillation.
But we've not seen that. So there's no lower limits, certainly for people with established coronary disease. International guidelines are recommending lower than we currently recommend. We'd recommend 1.5, 1.8 if you've got a 15% risk. I would suggest that probably should be lower, to be honest. But
well, is it Castellan in Amsterdam who sort of fantasised about a world with no LDL?
Yeah.
Zero LDL.
Yeah.
You'd need some expensive drugs to get it down, is the problem, of course. The drugs aren't that good. And for primary prevention, 5-year risk between 5 and 15%. So that's secondary prevention, that's high risk primary prevention, and that's primary prevention. And I'll show you the Canadian table. So they're the LDL targets, 5 to 15%, 40% reduction in LDL, greater than 15% than below. So you're saying 1.5 now?
So no, 1.8. So it's our agreed target for high risk primary prevention. And again, that was by consensus, Bruce. By consensus.
Sorry?
By consensus.
So this is the blood pressure. Interestingly, if they're home monitoring, do you think that's because you get rid of the white coat hypertension? It's a little bit lower at home?
I think so,
you know, because you'll all have these patients who come in and it's way up high and they get a machine and, you know, and we these days treat to home blood pressure rather than anything. And then below 140/90 if they've got high CVD risks. So and the difference between home and ambulatory is that. Now I've got, and we might have to email this to you. So the aspirin thing is changing, and Vanessa Selak has just published her new calculator, and I'll see if I can get it up on the screen here. So 5-year risk greater than 15%, then you would, and below age 70. Above age 70, evidence is insufficient. And for primary prevention, less than 15%, not recommended. So I'll just get this. This is going to be too hard for you to... So Vanessa Selak's at the University of Auckland, and she's just published this where you can individualize people's risks. So let's take... so the whole issue with... we'll say Maori man, deprivation 3, ex-smoker, blood pressure say 140, total ratio of say 5. So it gives this, so it says the risk of major bleed, so this is a 60-year-old Maori man with a blood pressure 140 and not a great cholesterol. So that's the risk of a major bleed in 5 years, and that's the number of, with aspirin, with no aspirin you'd have 8%, so there's a 1% gain there, and there's 1% harm there, so you're not getting very far is the issue. So, and I guess, I don't know, this is the other question, of course, once you've brought somebody's risk down with everything else, then actually they're not at their baseline risk, are they? And then you give them aspirin. Well, you are putting them at risk, I think, of a bleed. So what I've been doing on all my patients on primary prevention is saying on their 70th birthday, stop the aspirin, so at least the pharmacist knows to stop it. Because, you know, for us to be able to stop, that's pretty hard. So I write it in.
So Bruce, I understand the lack of evidence, in cardiovascular disease prevention. There isn't any for over 70. What about if you bring in the stuff around cancer of the bowel? You know?
Yeah, well, it's not in this equation.
No, well, we didn't put it in, so we debated this as well. I mean, do you think that's a reason, perhaps?
My take on the evidence is it's not, you know, it's all been side effects of other studies. No one's done a big study actually just looking at cancer as a prevention. And then you've got the screening program here now, of course.
Yeah.
I think you've got the money, have a colonoscopy, quite frankly.
Yeah.
You know, if you don't want to get bowel cancer, or a flexible sigmoidoscopy. So I'll just take you to the Canadian website. So it's, oops, hang on. So let's just get up. So it's called Therapeutics Collaboration. Now these two guys, one's a pharmacist at UBC, James McCormack, some of you may have heard of. And they do a podcast called Best Science Medicine Without the BS. So this is the only way you can get the New Zealand equation. So you go down to Tools, Therapeutics, Education, Collaboration, any of those, go down to Tools. Now the key thing here is the old equation's on your left. So you have to go down to cardiovascular risk assessment. And that's the old Framian one. You'll get it wrong if you do that one. That's the old equation. That's predict the New Zealand data. So I'll do this guy, 55-year-old Maori guy. He was male, he was Maori, didn't have diabetes. Blood pressure was probably 135. I think his lipids were a bit 135. Wasn't on treatment for blood pressure, wasn't on that. Total cholesterol, say it was 6 with a low HDL, so I think it was 1. And so that's his risk in 5 years. So for every 100 people who have to take a statin or a blood pressure pill, so lowering his blood pressure probably won't do anything. Oh yes, it will. Actually, it'll bring it down too. Anyway, I showed this to him and I said, do you want to take a pill every day for the rest of your life? He said, no. So now the problem for that on an equity issue is 100 men his age, 2 of them are going to die who wouldn't die if they'd all taken medication. But I felt I'd done my job because I'd fully informed him. Because he said to me, well, should I take this pill? I thought, I can't, you know. Like, I'd be happy to take a pill for that risk, but I'm a medic and I'm neurotic, you know. He's a healthy 55-year-old guy, but not on any medication.
So just to be provocative, I mean, that's part of the challenge, isn't it? You and I do perceive a 1% or 2% risk reduction as important. But that's difficult to actually communicate in patient-friendly terms, you know. And that's part of the challenge. I mean, the smiley faces is one way, may work for some of the population, but doesn't work for everybody. Thoughts on how we might do that better?
I think it's difficult. I have to say, I feel I quite like the smiley. We've done a bit of work.
In a 15-minute consultation,
yeah,
which you
well, that's
normally
right, yeah. I feel like he's properly informed. Got to do it again in 5 to 10 years, because of course his risk is going to go up. But here's a man, 55-year-old, not on any medication, and he wasn't excited by that. So that's serious mental illness. So that's a group not to forget about. They lived, is it 20 years shorter than people without? You know, of course the issues are the antipsychotics mess up the lipids, lifestyle's not great, not enough money, bad places to live. Congestive heart failure it's actually always been a risk, but it's now formally a risk. You know, once you've got congestive heart failure, you're at risk of CVD. Atrial fibrillation, we're going to be talking about that today, so that's becoming increasingly popular. I always like to say, if you're de-prescribing for somebody, your anticoagulants are probably the last drug you'd stop on somebody. You know, if you really wanted to get down to one medication and somebody needs an anticoagulant, and then the next last one you should stop would be the cardiovascular medications. You think of all the junk old people end up on, the cardiovascular ones are not the one, and there's quite good evidence about that if you want people to live longer lives. Okay. So dimensions of time. So time's interesting with blood pressure. So blood pressure differs by time of day, and it differs by time of year. It's actually higher in winter than it is in summer. So if you're struggling to get you have those winter days when you're not feeling great and all your blood pressures are up. Well, actually, there's probably a reason for that. There's about 15 millimeters difference between summer and winter. in people over the age of 70. So time of the century, of course, what used to kill people in the early 20th century was hypertension and syphilis and tuberculosis. And blood pressures are coming down in New Zealand in young people. Not treated, I'll show you a graph on that. So that's a 24-hour measurement. So it comes down at night time, goes up during the day, and then down at night time. So we all sort of know that. And it's interesting, if your blood pressure doesn't drop in the middle of the night, you're at more risk of CVD. And there's a couple of studies now showing if you take your medication at night time, you have a better outcome. If I take my medication, I just remember to take it. But actually, both studies out of a circadian rhythm unit in Spain, so who nobody has sort of heard about, but they're getting some increasing press, I think. So there's 2 studies now, I think. Are you aware? Just 2 so far, yeah. So a difference in CVD outcomes, which is interesting, because I've had patients taking their medication. I said, why the hell are you doing that? And they said, oh, just decided to do it. And actually, they may be doing themselves a big benefit. So that's the thing about older people, 15 millimeters difference. So I used to have a little lady who was in her mid-80s, and I used to have to stop her medication in summer because she'd get outside in the sun and get into the garden and do things, and she'd be keeling over with the blood pressure medication, come back into winter, and be back up again, So we literally, spring came and I learnt over a few years because I flattened her in a few summers. So blood pressure's falling, and this has been studied in college students. So it's not due to treatment. They're not a treated population. It may be the Barker hypothesis. So this is better prenatal care. So if you think current generations of young people coming through have had better prenatal care than previous ones, it's got better over the years. Rod Jackson thinks it's dietary fat. He thinks we're getting fatter, but we're eating better fats. So I don't know. I don't think butter's got anything to do with it, though. But so this is the trends in New Zealand. So it's coming down. New Zealand female, New Zealand male. So I don't know quite what's happening now, but interesting, eh? So okay, so these are the Yanomamo Indians. So that's a pretty amazing blood pressure. There's not going to be many people in this room with a blood pressure like that. I have the occasional very small female in my classes who have blood pressures like that, but you don't sort of see them. And the other thing is with their blood pressures, they don't go up with age. That's the key thing. And the way I think of it, I have a very simple pathophysiological. I think your kidneys are bombing out as you get older. By the time you're 70, you're down to 1. And I figure out that the kidneys are having trouble getting rid of the sodium, so they put the blood pressure up to push the sodium out. How's that for physiology? So that's the way I explain it. I tell people when they're 70, they've essentially got 1 kidney. It's not usually the best news for them. So causes of blood pressure. Now, when I was a medical student, it was said this was like 20% of the causes. But when you get into general practice, I hardly find anybody that I can find a secondary cause other than aging and putting on weight, which is the commonest thing, and inactivity. And I think in older people, it's probably due to their kidneys not functioning well. There's the 3 hormones that come out of the adrenal gland, and then there's the coarctation of the aorta, but you generally pick that up in younger people who'd have a high blood pressure. Had a friend at university who had that. So. That's my guide dog puppy. It's a cute photograph, isn't it? So how did they keep the puppy still? People say food. That's a Labrador. He'd be right in your lap if you had food. Yeah, they spin them around. So that's a vertiginous guide dog puppy. So he went to Christchurch, and a bit of a sad story. He's still alive, but things didn't work out so well from down there because he got spooked by the earthquakes. So he got repatriated to Auckland. So we got another tour of duty with him, and then he's medically retired out to East Auckland, so I get to see him still. So in terms of diagnosis, technically you're supposed to see somebody for 3 visits and do the average of the last 2 blood pressures. Now you've all had this situation where it starts coming down and you're trying to figure out what it is. And this is my own view, if it's that. I wish, because the medical students get very upset if they see a blood pressure like that, but I've had patients who've had that blood pressure for 20 or 30 years, and they're still chugging on. I'm sure you will have too, So it's not going to kill you tomorrow. That might. You want to see these people pretty quickly. And I've got a gem. I think this is one of my gems. It was called Urgent or Not Urgent. They looked at people with blood pressures in this range who were treated in the community or sent to hospital. Now, you've got to be a bit careful with this, because the people who were sent to hospital may have been qualitatively at higher risk. The health professional may have been worried about them because of their general condition. But actually they did better if they were treated in the community, even with a blood pressure like that. So rushing people off to hospital, you may activate the acute care machine. And once you activate the acute care machine, it's pretty hard to stop it. You've seen the 90-year-old in hypotensive, then as the demented grandmother of a friend of mine did, it activates the acute care system, and there's bells and whistles and everything. So there are risks of sending people to hospital, but I think you can treat that. So it's quite a useful study. It was on a big population. And this is from the SPRINT trial, which was the big one published 2016, I think. Numbers needed to treat, so this was treating to 140 or 120, and this was in fairly high-risk people. So they had 25% of them, I think, had coronary heart disease, had quite high CVD risks. Numbers needed to treat to prevent an event were 22, and 38 to prevent an event, a death. So that was, they got down to about an average blood pressure of 123. And the issue is it does require probably at least an extra pill on average. But interesting, there were fewer serious falls in the intervention group. It wasn't statistically significant, and I think they had fewer CVD events. I think they felt more lightheaded, they had more side effects, but in terms of actually keeling over and hitting the deck, they had fewer. And I suspect they had fewer CVD events. I don't know what your view. And actually, if you look at in the back pages of the study, you look at it, the people who were frail, they had this frailty index. Now, these weren't people coming in on walkers, but they were mobile people. They weren't sort of like in a wheelchair or anything. The frail people actually did better than anybody else. And I think we, again, if you think somebody's physically frail, their cardiovascular system's probably frail as well. That's the way I think of it. And so maybe you want to get their blood pressures down. So, I mean, you don't want to make them fall over and break a hip, but you don't want them at 85 having a stroke either if they don't need to. So these are the initial treatments. So lifestyle, smoking's the big one. You halve somebody's risk if you can get them to stop smoking. All the other risk factors, it's less than half, but with smoking, and we need to know what the absolute risk is. So these are the lifestyle things. So weight. In the trial they did in Glasgow, where they got 49% of people to stop being diabetic. So these are people within 6 years of getting diabetes. They randomized them to an 800-calorie diet a day. I mean, it was like next to nothing. 3 sachets of Optifast and a cup of vegetables to keep the bowels going. In the intervention group, they had to stop all the blood pressure medication and all the diabetes medication. Otherwise, people would have, because once you start doing severe weight loss, things really start happening. What happens to the pancreas is they found started producing more insulin and less glucagon. So it's fat around the pancreas was the problem. They lost 10 to 12 kilograms, and at 1 year, 49% of people lost their diabetes. At 2 years, it had dropped to 39%. I mean, it's going to start dropping down. But weight loss, I think, if you try to get people to lose weight in our society without something as intense than that, I mean, I'm sure you've all tried to get people to lose weight. You probably try to lose weight yourself. It's very hard, very hard. Too much cheap, yummy food. Rod Jackson. Quote Rod.
I've seen him eat it as well.
Cheap, yummy food.
Yeah.
Lack of exercise and high salt. So that's 21st century New Zealand, isn't it? You know. For alcohol, it's a bit sexist. Men can have. Alcohol's more a problem for men of more than 3 a day, and women more than 2 a day. The issue about stress, I think it is a bit of a risk factor. I know when I get stressed, my blood pressure is higher than when it's not. And these are other things to think about. Licorice, fortunately, you have to eat 100 grams a day. So that's a hell of a lot of licorice. So steroids, obviously, but people would be getting that for something else. Non-steroidals, I'm going to talk about a case of that. Wonderful drugs for your aches and pains, but a bit rough on the blood pressure and kidney and CVD. And then Sudamol. Sudamol is one of my favorite drugs because I can now prescribe it on e-prescribing for patients with colds. So somebody comes in wanting an antibiotic for their cold, I can say, well, I can make you feel better today. Because you don't need the controlled drugs form anymore, you can just do it on an e-prescription. So you want an antibiotic, it's going to give you diarrhea and won't help you on average, but a bit of Sudamol will, and it's not a hassle to prescribe anymore. And the 8 tablets I give my local accountant isn't going to end up in the methamphetamine cycle. Most of the methamphetamine's coming across the border anyway. I don't know how much is made locally anymore. So this is my easy to hard hit list. So drug therapy is actually the easiest probably. Exercise probably number 2, and then smoking cessation. Dietary change is difficult. Sodium population reduction is something you do on a population basis. In the UK, the bread makers all agreed to drop the amount of sodium in the blood pressure, and in the bread. And nobody noticed, they didn't tell anybody, and nobody noticed. But if you go and look on the side of a bread packet, there is an amazing range of sodium in breads. The cheap white stuff is full of sodium. Alcohol, probably a population basis. We need to do. I don't think we take alcohol serious now. And I think I have groups, I've done this with groups, traditionally with GPs, 100 in the room. How many of you have got a patient to lose 10 kilograms and keep it off for 5 years? One GP puts their hand up. I mean, that tells you something of how difficult it is to get weight loss in our community. Smoking, just ignore this. This just shows you, I could increase my CVD risk if I took up smoking, or I could put on 40 kilograms. So smoking is equivalent of putting 40 kilograms on. So that was the paper in the Lancet a few years ago. So that's sodium. One of the games I play with the med students is I have a bag of chips and a bag of cornflakes, and I say per 100 grams, which has got the most sodium in it, it's the cornflakes. The sodium's coming down in both. The game's getting harder to play, and then I hand out packets of chips to the medical students, so they like that lecture, and the packet of cornflakes as well. So yeah, so that's sodium. European guidelines are ACE, diuretic calcium channel blocker. They then go to spironolactone, which I find is a very difficult drug to use, because when you prescribe, as a prescriber, when you prescribe spironolactone, the monkey's on your back. You've then got to chase the serum potassium. And you know, you've all had this situation, I'm sure it goes up. And then what do? You have sleepless nights thinking, is it going to keep going up? And actually, patients don't like it very much. There was a case control study in the British Medical Journal about 15 years ago, and they were concerned about it causing ulcers, actually, but it did cause a lot more GI upset compared to people who are on different drugs. But in Europe, it's the number 4 drug. Here, it's number 5, I think, isn't it? We would probably go to a beta blocker first. And I think with alpha blockers, there's no evidence of, no one's shown it's better than, it was significantly worse than chlorthalidone in the ALL-HAT trial. I don't think there are any trials to endpoint on alpha blockers. Are you aware of any?
There's one trial that I've got a slide, I can show it a little bit later. I